So on today's discussion, we will discuss a systematic approach for interpretation of orthopedic x-rays. Now, the word orthopedic refers to bones. That's what we mean. Okay, so we will discuss a systematic approach on how to interpret x-rays of bones. Then we will understand the principles of viewing x-rays. Followed by that is an overview of fractures, some x-rays, and a short discussion on DEXA scanning. Okay, so within the following section, we will start discussing a systematic checklist. And within this section, we will mainly attempt to utilize some broad, basic principles, which should be, I would like to say, should be of universal aid whenever you approach any orthopedic x-rays. And by that, I mean that they should be useful within any context for a bone x-ray, okay? So, rather than just reading the systematic checklist out loud, I'll just move to the next slide, and I will try to discuss each item from our systematic checklist on its designated slides. So number one, or for the first slide, this is the most basic and intuitive, yet very easy to neglect point, which is you have to really make sure before you start reading an X-ray that this is the right X-ray. And what do I mean by that? You have to confirm that you're looking at the right X-ray, which means that you have to make sure that you've checked the patient's details and make sure that you are looking at their most recent X-rays. I've heard a lot of stories about surgeons who, within their preoperative surgery preparation, they've been checking the wrong images and they went to operate on the wrong side of the body. I've heard that so many times. So always check that you are reading the right, that these are the right details for the patient, and also make sure that this is the most recent X-ray. And remember that you need to understand which side are you looking at, because I've heard so many horrific stories of people operating on wrong sides because they don't do this very intuitive point. Okay, so as I said, this comes in also, yeah, you have to make sure that this is a very recent X-ray, and this comes in very handy, especially if you're navigating an electronic medical record and you have several images from separate dates for a single patient. This tends to be very common if a patient is old in age. So if you have an old patient that's when they're within their 70s, it's very common for these patients to have plenty of X-rays on their records. Just make sure that you're looking at the most recent one, because that's the most deserving of your attention. Okay. Now, following that, now that you made sure that you're looking at the right image, now it's time to look at the image. Initially, you need to make sure that the bones are naturally aligned. Otherwise, you don't really get a point for noting that you are presented with either a fracture or dislocation. So what you need to do, as I said, you just make sure that the bones are naturally aligned, and that's very easy and simple to do on your first look. Now, if we're discussing a fractured or a dislocated bone, mostly this fractured or dislocated bone will be surrounded by some sort of secondary soft tissue injury, which you may not really visualize on a simple X-ray. Okay, so an X-ray is not really the best modality if you want to examine the soft tissues. However, if you look closely within the shades of gray, you might get some understanding of what's going on with the soft tissue. So now let's assume that you are faced with this foot X-ray on your exam, and the clinical vignette indicates that the patient has suffered some trauma to the forefoot. Let's say that on a clinical examination, they have a very evident, very clear dislocation, and the doctor performed an X-ray to exclude any underlying fracture. So by looking at this image, you should note that there is no clinical or there is no cortical breakage anywhere. However, the bones are not aligned. So if you look at the image, there's no cortical breakage, which means that we're not actually seeing any sort of fracture. But as is very clear here, this is not the proper alignment of how the bones should be. Now, this should confirm your initial suspicion. As I said, radiology acts within the context of medical history. So as long as you took your clinical history and you performed your medical examination, you'll probably be requesting an X-ray, and you already have an idea in mind that this patient probably has some sort of dislocation. Now, this image will only serve to confirm your initial suspicion that this patient has a dislocation in the middle toe. specifically here at the metatarsophalangeal joint, okay? Here at the metatarsophalangeal joint. So now after that, we checked the patient and image details, and we scanned the image for any issues with alignment. It's worthwhile to check the spaces within the joints. So these spaces are usually narrowed if the cartilage is lost, and they would be widened if there is any sort of dislocation. Okay, I would know the reasons for narrowing and widening for my MCQs. Okay, so I know that they are narrowed for cartilage loss, and I know that they be widened for dislocation and dissociation or dissociation. Okay, so this is an image that shows us some examples for the point that we just discussed for the joint spacing. So this is a patient who has osteoarthritis in the first metatarsophalangeal joint. Now, this is a very uncommon place to have osteoarthritis, because if you remember from your pathology, so osteoarthritis is a disabling joint disease that's characterized by some sort of degeneration of the joint. And by the joint here, I mean the articular cartilage, the subchondral bone, the synovium at any point of a joint, okay? So osteoarthritis can be of various causes. There can be so many causes for osteoarthritis, but the most notable cause and the most common cause is advanced age. And the reason behind older people having osteoarthritis is overuse. It's usually, I'm not saying always, it's usually a disease of wear and tear, okay? So because it's a disease of wear and tear, and it's because a disease of overuse, it mainly affects the weight-bearing joints, the joints that are heavily used. So mainly we're thinking of the hip, of the knee, of the we're thinking of the hands, maybe the vertebra. These are the points. These are the places where you would suspect to see osteoarthritis. However, this patient has osteoarthritis in an unusual site. So even though, as I said, people generally tend to think that osteoarthritis is because of wear and tear, but we have new research that points that there are other causes. Sometimes these patients may have some pre-existing joint abnormalities. Sometimes it's genetics, maybe some local inflammation. So there are a lot of causes that can lead to osteoarthritis other than wear and tear. So this is why you shouldn't exclude it just by looking at an image of an unusual site. Now, when you're looking at this image, you will see that we have these prominent osteophytes at the metatarsophalangeal joint. And osteophytes, I'm talking about these pyramidal shaped outliers. And the word osteophytes means just we have an extra area of bone. So this shouldn't be present here. We have this extra area of bone. These are what we mean by osteophytes. And usually we should see osteophytes at the area surrounding the joint, or at the cartilage zone of the joint, okay? And now if you look at these arrows, they're pointing at the joint space, and they're showing us that there is joint space narrowing. And how do we know that there is joint space narrowing? Just by comparison, because you look here, you see that this is the normal joint space, but if you look here, you look that the bones are very close to each other, okay? So in summary, in patients who have osteoarthritis, we tend to get loss of joint space, and as we said, if you're seeing if the joint space is narrowed, then you should start suspecting that these patients have some sort of cartilage loss. Okay. Now this narrowing, or this space narrowing, is, you can see it's slightly more pronounced here at the medial side. You can evidently see it here at the more on the medial side, and on the lateral side, maybe the spaces are more normal. They're not normal, but they're more normal than the medial side. Now, I know that some of you are probably looking at this shade of black and thinking, okay, this is supposed to be the joint space, but no, this is just weakened bone, but this is still bone. Okay, so here we can see a little bit of joint space, but however, here it's almost obliterated on the medial side. Okay, so we can say that this patient, if they're presented to us in a clinical vignette, most likely the patient on the question will have something like they have long-standing forefoot pain, since this patient has osteoarthritis in their forefoot. Okay, so if you're asked to diagnose this, you should say that this patient has osteoarthritis of the first metatarsophalangeal joint. and you should note the osteophytes and say that these osteophytes are a strong evidence that this patient has osteoarthritis, okay? Also, the narrowing of joints, you should actually point that out. So now, after we have learned that we need to check the patient and the image details, and after that, we started scanning the image for any issues with alignment, and we started assessing the spaces and the joints. Now we just need to look at the cortical outline. So this is quite important for us if we want to spot any fractures. So if you start looking at this image, and this image here is a good example for us. This is what we term as a boxer's fracture. Now, this is referring to the sport of boxing. Now, a boxer's fracture is a fracture of the fourth or fifth metacarpal neck, is a fracture of the fourth or fifth metacarpal neck. And it's called a boxer's fracture because it's usually caused by a closed fist coming in contact with a solid surface. So you would imagine that if you're a boxer, then you would tend to get this boxer's fracture more frequently. Now, this is just an example for us to how to start to diagnose a fracture based on the cortical outline. Now, if you look at this image, all you need to do with your eyes is follow the cortical lining as I am doing with the mouse. So just keep following the cortical outlining, and there's nothing weird with the cortical outline. Now, if you go to this bone here, and you just keep moving with me with the mouse, now we start to see something of discontinuity here. Now, this discontinuity here that is very well marked on this image is just noting that this person has a fracture. And as I said, if you have a fracture on the fourth or fifth metacarpal neck, then this is what we term as a boxer's fracture, okay? So let's proceed from here. So another item on the list is looking for the fine matrix or the fine white lines, which we call trabecula. Now, this is not going to be very useful for you if you're looking at an image on a projector, because it's not going to be visible. And most of the pathologies, or if not all of the pathologies that we will be addressing, will not really require you to see the trabecula to diagnose them. Okay, so this is not going to be very handy for you on your exam, but just know that you need to look at this in your real practice. So let's just look at an image. So this is going to give us a better understanding. So this is what we mean by the trabecula. Now, if you're not really seeing it on this image, it's just, there's a good overlay on this one that shows you what we mean by trabecula. So most bones have these defined trabecular patterns. It's just part of the normal bone architecture. Now, if you start looking at these trabecular patterns, you should start getting an understanding of how a normal pattern looks like by looking at many images. In some images, just a difference in this architecture will start to hint you towards understanding that there is some sort of pathology with the bones. Now, I'll be honest with you, you should not be expected to diagnose a patient based on the bone texture. That is very difficult, and it would not show on your projectors or on the exam projectors. But however, just keep that in mind in case this is part of some MCQ where you need to choose something that's supposed to be on the checklist from the choices, okay? And finally, the last thing on our checklist is that we need to check for clues within the soft tissue. So this, as I said, this can be very challenging in an X-ray, but it's very useful in fractures which are not very visible. But keep in mind that within radiology, you are looking for things within the context of the patient's history. So if you are given a patient who has suffered serious trauma and the physical examination is showing that the patient has a lot of pain and they have swelling and the tissues are edematous, then you should look at the same anatomical area that you have spotted on your physical examination within the radiological imaging. So if you know that the patient has swelling and has some sort of inflammation, let's say at the metatarsophalangeal joint, so when you look at your X-ray, keep a good eye for the metatarsophalangeal joint. That's how radiologists work. They don't work by spot diagnosis unless they're extremely experienced, okay? So after that, this image is giving us an idea of how we can use the soft tissue to guide us while looking at an image to spot a fracture that would have been easily missed if we hadn't noticed any problems with the soft tissue. So this patient has what we call a tibial plateau. So tibial plateaus are they are periarticular injuries of the proximal tibia, and they are most commonly associated with soft tissue injury. Now, if you look at this image, it's very difficult to spot this fracture. It's very difficult. It's not easy to look at this. Even if you're following the cortical line, it's very easy for you to miss this. However, it's much easier for you to spot this collection here, which is well demarcated on this image of blood, especially if you have a good history, given that this patient has a collection of blood or have swelling underneath their kneecap. If you see that, or if you hear that within your question, then you should start suspecting that something is causing this collection of blood underneath the kneecap, and then you should start looking more carefully within your image because you're searching for a fracture. Now, realistically on your exam, because they will probably be utilizing the same images, so just keep an eye that this image, even though it seems normal, just keep an eye for this image and remember that this is a tibia plateau fracture, okay? So now that we covered our checklist, it's time for us to discuss some basic principles. But before we proceed, I would very much like it if anyone has a question that they would like to share it with us. So please feel free to use the chat box or use the mic, whatever you prefer. And if you're comfortable with everything that we discussed so far, just please tell me that you're comfortable. Everything is okay. Any questions? Everyone is okay. So everyone is okay. Okay, good to know. Now, as I said, we just covered our checklist, so it's time for us to discuss some basic principles. So whenever we are viewing an X-ray, as I said before, and I showed you the famous image of Prince William, two views are better than one view. It's not that two views are better than one view. I always like to say, as all radiologists like to say, one view is no view. So if you're looking at an image from one view, you should not really say that you are capable of visualizing the structures that you're looking at. You need two views to make sure that you are actually seeing what you think that you're seeing, okay? And sometimes you would miss a lot if you were just given one view. After that, you need to check all the available images. So if a patient has a CT and an X-ray on their file, you have to check the CT and the X-ray. If the patient has an MRI and a CT and an X-ray, you have to check all of them. Make sure that you're checking everything. And if the patient has images of both sides, if that is imaged, you have to compare both sides. This is a very useful tool for people who don't have a trained eye. If you don't have a trained eye, like me, for example, I'm not a radiologist, so my eye is not very well trained for radiological imaging. So in that case, it comes in very handy if you can see both sides and start comparing the right side to the left side. And if it's available, as it said, you should always compare with old X-rays. Now, old X-rays will always give you a hint on what caused the pathology that you are seeing. So sometimes you'd see a patient who has a fracture, and this fracture is due to minimal trauma. So maybe this patient was just walking the street and their leg hit something trivial. And after that, these patients start suffering a full-on fracture, like have a full-on fracture in the leg. So these patients, this should warrant you to suspect that something worrisome is going on with these patients. Now, if you have earlier X-rays for these patients, you might start spotting lytic lesions, which mean lytic, by lytic, that comes from the word lysis. So you start seeing lytic lesions on old X-rays, and this should hint you towards that this patient possibly has maybe something like multiple myeloma or so on, okay? So this is showing you as I said, the utility of having two views. So as I said, as the old saying goes, one view is no view. So let's take this as an example. Now, if you're looking at the anterior-posterior view, it only shows a very minimal cortical bone irregularity. So this is where the fracture is, and this is where the fracture is, okay? So this is where the fracture is running. Now, if you look here, this is where the fracture should be. Now, it's not very visible. This is extremely easy to miss, especially that you cannot easily follow the cortical outline in an anterior posterior view, okay? So as I said, you need the lateral view because you will not be able to spot everything on this view. And sometimes you might not spot something on the lateral view, which should be visible on the anterior posterior view. So none of them is actually superior over the other, okay? So as I said, if you're looking at the lateral view on this image, it's going to show you an obvious bone injury. Now, if you're required to diagnose this on your exam, you have to know that this is an oblique fracture of the distal fibula. So this is an oblique. Oblique means that it's not transverse. So it's not going just like this horizontally. No, it's going with an oblique line. So this is a line that has some sort of angle that's not 90 degrees, okay? So this is an oblique line, and we'll be discussing types of fractures very shortly, but this is an oblique fracture, and this is in the, as I said, in the distal fibula at the level of the ankle joint, okay? Okay, any questions so far? So as I said, this is, excuse me for pointing wrong, this is where the fracture is. Even I wasn't able to spot it quite clearly from the first spot, okay? So as I said, it comes in very handy for you to compare one side with the other. So, so let's say, okay, this is a patient who has a fractured neck of the right femur. So just as a simple introduction, let's talk for 1 minute aside from these images. Just want you to know that the images of an asymptomatic contralateral side, or the other side which has no problem, is usually not acquired if you want to assess any bone. So if a patient has an injury to their shoulder, for example, the right shoulder, it's not orthodox, it's not routine for you to require x-rays for the right shoulder and the left shoulder and start comparing both, okay? So sometimes you will be lucky enough that you have an old image of the contralateral side. Sometimes you're being faced with a joint that is usually as like a standard practice usually shows both sides of the joints, like for example the hip pelvis joint. This is where you would get something like I just gave as an example, and then you will be able to compare the symptomatic side and the asymptomatic side. So for the images that we are given, you can see that we have the right side and the left side. And the image of the pelvis shows some subtle irregularity of the cortical outline on the right femoral neck. So remember, you're looking at radiological images as if you're looking at a mirror. So this is the left side. Now this is the right side. Now, if you're following the cortical outline, so everything is normal as I move with the mouse, everything is normal, everything is normal. Okay, okay. And then I have this sudden angle here, and I have this cortical outline that's going within the image where it's not supposed to be. And this is very well outlined on this side. This should warrant you to understand that you're looking at a fracture of the right femoral neck, okay? So if you're not very sure, if you can't be 100% sure that you're looking at what you think you're looking at, then using the other side is very useful, because if you start comparing both necks, you'll start noticing that this is a longer neck. You'll start noticing that the cortical outline is much more uniform on the healthy or on the asymptomatic side, okay? So this is something that should increase your confidence and make you sure that you're looking at a genuine abnormality, if that's the right way to say it. So maybe you're looking at this and you on your exam and you're required to diagnose this. So to diagnose this, you just need to say that this is a fractured neck of the right femur, okay? And as I said, sometimes you will be given an old X-ray on the patient's file. So maybe a patient had an X-ray in, let's say, 2020, and now they had a new X-ray on 2023. Now, this is going to be very useful for you. So an old saying goes is that an old X-ray is the cheapest test in radiology. So this is the best test that you can get in radiology, because it gives you a very good idea of what is the backstory behind this patient. So sometimes you're uncertain about an abnormality, and you're just given an image, an old image of the same area in question, and this kind of increases your diagnostic confidence. So if you look at this image here, so this is an old X-ray. Now, if you're looking within the bone cortex, you'll start seeing here like leave the cortex and start looking within, you'll start seeing this area of darkness, which is well marked here, the lytic lesion here. And then you start understanding that this patient has some sort of lysis. Now, maybe this could be also because this patient maybe has some sort of metastasis to the bone. So maybe this patient suffers from cancer. Now they would come to you to the emergency room with a sudden fracture from a trivial trauma. So this patient might have been just walking their dog. Maybe they've just been they've just been doing some minimal housework, and then they get this full-on fracture, and you start to be worrisome. Okay, what would cause this trivial incident to cause such a large fracture in this patient? Maybe if you look at an X-ray and you spot the lytic lesion, that's going to guide you to understanding that possibly this patient might have some cancer, and maybe that's why they have bone metastasis. Okay. Now, a last good piece of advice is that you need to keep your eye on the ball. Now, this is just a term in sports, which means that you need to focus on the details in question, not on anything that is not within the question that you are giving. So this is a good image because it says here, when you're looking at an X-ray, always keep the current clinical features at the forefront of your mind, which means that you should be thinking within the context of the question. You don't have to figure out extra stuff that you have not been questioned. Okay, so if this patient's history is pointing towards that they have had some trauma and they have some limitations to their movement, and they're presenting to you with an inflammation at the site of trauma, then please always keep your eyes on the suspected area or the suspected anatomical area where you would be thinking that this patient has a fracture. Okay, so you might look at an image like this and you'll be very intrigued by this uterine fibroid, and maybe you would look at this at your exam and you say, okay, I want to comment on this, that this patient has a uterine fibroid. However, this is useless information for your patient for the issue in question. So this patient came to you with trauma, and the emergency room people, they requested you to tell them what's going on with their femur head. So you just need to comment on this. Now, you may say at the end of your report that you spotted an incidental uterine fibroid. Now, that can be useful on your report, but what you need to discuss initially is the fracture of the right neck of the femur. And this is, as I said, if you're looking at this side, just follow the cortical outline and you're going like this, and then you have this angle here that is abnormal, and you have this very shortened neck. How do I know that this is a shortened neck? Just compare with the other side. This is a much longer neck. And you can start looking on the contour of this bone, and then you will very visibly notice that something is wrong on the other side. Okay. So I think, I think this is okay. So now let's discuss some fractures, but before we discuss some fractures, please feel very free to send me any questions on the chat box. Confirm that everything is clear. Everything is clear. If there's any image that you would like me to revisit, if you would like me to give extra notes on, feel free to ask me. I don't mind going back in slides. Just tell me if there's anything wrong with it now. So is everyone okay? Can you please confirm or deny, whatever you feel? So everything is okay. Good to know. Okay. So now, before we start discussing fractures, the first order of business is that we need to learn the lingo. You need to understand the terminology that we use to describe fractures in reports, because you will be communicating with other consultants and other specialties, and we need to agree on a certain language so that everyone understands what's going on. Now, this is particularly very important, the slide. These are 5 points that you need to comment on whenever you report a fracture. So you must always discuss or say whether this is an open fracture or a closed fracture. Now, keep this in mind if you're commenting on a fracture on your exam, okay? So I have to say, is this an open fracture? Is this a closed fracture? Where is the anatomical site? You need to describe the fracture line. You need to describe the relationship between the fragments of the fracture. And you will not need to describe this because you will not be performing physical examination on the patient. So you will not really have a good idea of what their neurovascular status is, okay? So since I started throwing big words like open fractures and closed fractures and fracture lines and so on, now I think it's my duty to start giving some meaning to these words so you guys can utilize them well on your exam. So just without going into any deep comparisons, just keep in mind, if the bone pokes through the skin, if the bone can be seen, if the patient comes to you in the emergency room and you can visualize their bones, then this is an open fracture, okay? So maybe you get a patient who's been in a terrible car crash and they have a very deep wound, and this deep wound exposes the bone through their skin. So it's not that the bone poked out of the skin, it's just they have a very terrible deep wound that you can see the bone through the skin from. This is also an open fracture. So if you can see the bone, that's an open fracture. If you cannot see the bone, that is a closed fracture. That is just all what you need to know about open and closed fractures, okay? After that, you need to describe the anatomy. And you do that by stating the side. This is extremely important. Guys, I've heard dozens of stories, horrifying stories of the most, I want to say, well-known surgeons who would go and operate on the wrong side, just because they were not well oriented while looking at the patient's file on which side has the problem. Now, maybe you're thinking, oh, shouldn't the patient just make the surgeon aware that, doctor, I have an issue on the right side, not on the left side? Well, most probably your patient is not even awake. Most probably when the surgeon comes into the room, they've underwent anesthesia and they don't feel anything. So this happens a lot, okay? Just please make sure that whenever you're describing anything, you need to say, okay, this is on the right side, this is on the left side, and then start saying, what bone are you looking at? So maybe I'm looking at the humerus. So I say this is on the right humerus. And then I need to start saying where the fracture is exactly. And by that, I mean, we need to say, is it proximal, is it middle, or is it distal, okay? So proximal, we always never see, whenever we say anything is proximal, it means it's closer to the head. Whenever we say it's distal, it's further from the head, okay? So let's look at this slide. Now, after we've said, after we've mentioned if the fracture is an open fracture or closed fracture, after we clearly stated where the anatomical location is by saying the side, the name of the bone, whether it is proximal, middle, or distal, we need to describe the fracture line. Now, these are 4 types of fracture lines. Now, the first one here, this clean horizontal one, this is called a transverse. This is called a transverse fracture line. Now, this one here, which is angular, like this, I think this is a 60-degree angle. Now, you don't need to say this is a 60-degree angle. I'm just saying this for explanation. Now, this 60-degree angle here, this is what we call an oblique. This is an oblique fracture line. Now, this one here is what we call a spiral line. Why do we call it a spiral line? Because the oblique one is clean cut on every trajectory. So if you look at it from any side, you'll see that it's just one line going through the bone. Now, these spiral lines, they're just moving haphazardly between both sides of the fractured bone. However, you just get 2 at the end of this sad incident, just get 2 pieces of bone. So I know the fracture looks weird, but however, you have one side of the bone and you have 2 sides of the bone. However, you have more than 2. If you start seeing these shattered bones, we call this a comminuted fracture, okay? A comminuted fracture. So a comminuted fracture is just a very fancy way of saying that the bone is shattered. It's not a clean fracture as it is with the first 3 ones, the transverse, the oblique, and the spiral one, okay? Now, this image was not on your original slides, but I think it will come in very handy for us when we try to understand this point of the relationship of fracture fragments. So when we speak of the relationships of fracture fragments, this is a fracture fragment, and this is the other fracture fragment, okay? So because there is a fracture, so it divided the bone into 2 fragments. We're not going to call this side half of the bone and half of the bone, just going to term them as fractures, okay? Now we need to describe the relationship between them. So what we're looking here, or what we're looking at here, this is called a distraction. This is a distraction, which means that the bone is still within its normal alignment. There's nothing wrong in how the bone is aligned. However, there's a distraction. The bone is not in continuous, is not continuous with itself because there's a fracture here. Now, sometimes you get a displacement, and a displacement could be lateral or medial, okay? It could be lateral or medial. Now, remember, this is not how this bone should be looking like normally in your body, because it shouldn't be horizontal. So this, you should be looking at this as you're looking at any person's leg, okay? So here we see there's a lateral displacement. So this is a lateral displacement. The fragment is moving laterally. It's not in alignment with the original fragment. So this is what we call a lateral displacement. And it says without angulation. Now, here we call this a complete or a 100% lateral displacement. What's the difference between this one and this one? Here, you can see that if these two bones are approximated to each other, parts of the bones will collide. So you'll see that maybe up to 50% of the bones will come in touch. Now, a complete displacement means that both these bones, if you approximate them, nothing will touch from the fragmented side, okay? So this side will never meet with this side if you approximate both fragments, okay? And this is without angulation. Now, normally, if a patient comes with complete lateral displacement or complete medial displacement, now normally these patients will have a shortened limb. So you'll start seeing that one of their legs is much shorter than the other. And I think it makes 100% sense because you can see now the bone is occupying a shorter span than it should normally be, like how it looks here, for example, in a case of a distraction. Now, this is what we call an angulation, and just this term is derived from the word angle. Now, you can see that this bone now, the fractured segment, is not just displaced, it's displaced, and it's displaced at the 30-degree angle. So this is what we call as angulation, okay? So sometimes you might have a patient who has angulation without any lateral displacement. Sometimes you might have angulation with lateral displacement. This is a patient here who has complete medial displacement and some angulation, okay? So I just wanted to go over these terms. They're not part of your original slides, so they're not part of your exam, but without them, these words they're just buzzwords. They don't make any sense, okay? Just wanted to say this within the context of this image, so you guys would start having an understanding of what we mean by displacement, angulation, and so on, okay? And lastly, you just need to comment on the neurovascular status. So if the patient has any neurological deficit, so let's say maybe they've had a fracture to their forefoot and now they are incapable of moving their toes, then you should start mentioning that also. But however, this is something that you should see on clinical examination. So there's no image that's going to give you any information about a neurological deficit, okay? So before we get into the fun stuff, please tell me if you have any questions, okay? Any questions? So the original slides, they have I think a recording at very random slides. I don't know. It's just like maybe one out of every 15 slides has a recording. So that's why you guys start hearing a different voice at some points, okay? So just before we proceed, does anyone have any questions? Is everything clear? Any questions so far? No question, okay. Now, let's start by looking at some x-rays. So this is a normal clavicle. This is how a normal clavicle looks like. This patient has, or this, not say patient, this person, someone said, can we please revise the slide that's the angulation slide? Yes, please. We can do that. So, as I said, so if a patient has a distraction, it means that the bones are aligned. So you see, if I just go through this bone with my mouse cursor, you can spot that the bones are normally aligned, okay? So this is a displacement. Now, if the patient has an angulation, it means that it's not that if I'm going through this red line here, sorry for skipping the slide. So if I go through this red line here with my cursor, I'm not able to go through the rest of the bone unless I go with a 30-degree angle, or let's say here it's not 30-degree, here I'm going 150 degrees, okay? Unless I go in a 150 degrees angle if I want to proceed with the same line that goes through the middle or the center of the bone, okay? So this is an angulation. It means that I have to go with an angle if I want to keep following the bone through the center. So again, this one here, this bone is still going on the horizontal trajectory. Everything is normal. But if I want to go through the center of the bone, I'm going to have to go through a 135 angle through this line, okay? So this is what we mean by angulation. So it's not just that the bone is fractured, it's fractured and it's just moved at an angle very far away from the fracture site. Now, for the person who asked me the question, is everything clear at this point? Can you send me a message? Or would you like me to further explain this? Clear. Okay. Thank you. So let's go back to where we stopped. So as I said, this is a normal image of a clavicle. And we can see here that the patient has a continuity of the cortical outline, not seeing any fracture lines. So this is how a normal clavicle should look like on an image. Now, this is a picture of a patient who has a fracture of their clavicle. Now, if you're following the cortical line, oopsies, something is wrong, right? So this patient has a fracture. Now, this is a transverse fracture. This is a transverse fracture or an oblique fracture. It's going to be better visualized from another side of the CT. But you can see here by looking at the fracture line that it's just a straight line. And here's just a straight line. So you can start assuming that this is more of a transverse or an oblique, either this or that. You can't really make sure because, as I said, you need to look at this from another view. So it can either be a transverse or an oblique fracture. We have to say that which clavicle we are looking at. Now, it's like looking at a mirror. So can someone tell me, are we looking at the right side or the left side? Feel free to use the chat box. Is this the right side or the left side? Right side or left side? So perfect. So this is the left side. It's like looking. Exactly. It's like looking at a mirror. So this is the left side. Let's say that there is either a transverse or an oblique. I can't really tell because this view is not very helpful. All I can see is that the fracture lines are straight. So this is either a transverse or an oblique it's in the middle of the clavicle. So I say a mid shaft fracture. Now you need to comment on the displacement. So are these bones continuous with each other? No. So this is not just a distraction, okay? So there's an inferior distraction or an inferior displacement of the distal part of the bone, okay? So this is an inferior distraction or an inferior displacement of the distal part of the bone. Now remember, if you're moving away from your spine, that is distal. If you're moving towards your spine, that is proximal, okay? Now, this is a normal shoulder joint from an anterior-posterior view. Now, as the slide just reads, the humeral head and the glenoid contours are aligned normally. So this is the humeral head. And this line here, this shade of darkness, this is the glenoid. So the key points here that I would like you to know is the anterior-posterior view is usually the standard view in the context of trauma. And if a patient has a shoulder dislocation, it's way much more common for them to have an anterior dislocation than it is for them to have a posterior dislocation. This is because the anterior support of your joint, of your shoulder joint, is way much weaker, okay? So that's why you get an anterior dislocation is way much more common, and the trauma that will cause an anterior dislocation is way much more common than a posterior dislocation, okay? And an anterior dislocation, as I said, it's not just more common, but because it's more common, you need to know how it would appear on an X-ray. And on an X-ray, we'll start seeing that the head or the head of the humerus will start locating anteriorly to the glenoid. So it's not going to be aligned with the glenoid as it is here. You start seeing that these bones are overlying each other and the head will be anterior to the glenoid. Sometimes it'll be even inferior to the coracoid process. This is the coracoid process, okay? When I'm pointing at here with my mouse cursor, okay? So this is a patient here who has an anterior shoulder dislocation. So as we can see here, this is the normal glenoid here. So this is the normal glenoid. And as I told you, the head of the humerus is lying anterior to the glenoid and is inferior to the coracoid process. Okay, so this is the coracoid process. You can see the head of the humerus lying inferiorly to it. So on your exam, just keep an eye for the glenoid process. And if you see that the bones are not aligned, as I said, it's very safe to assume that this is an anterior dislocation, because posterior dislocation are not very common, and they're actually not part of your curriculum. So don't over stress on whether this is an anterior or a posterior dislocation. Now, the image we have here is showing us a humerus fracture. And if you look at the lateral side, well, it's not really a good side to look at. But if you're looking anterior-posteriorly, the fracture is very visible on this side, okay? Now, if you're looking at both sides, you'll start noticing that this patient has some sort of lytic lesion. And I'm saying this because if you look at the cortex even beyond the fracture, you'll start seeing that it's not as white as it needs to be, okay? So this patient seemingly has some sort of lytic lesions. As I said, this can be because the patient has metastasis. So maybe the question will be giving you a patient who has a history of cancer. Sometimes they might have specifically, they might refer to the disease multiple myeloma, okay? Now this patient needs to have a fracture after a trivial trauma to the upper arm. So as I said, maybe this patient was doing normal housework and then they suddenly got a full-on fracture. So this should warrant you to think that maybe this patient has some sort of pathology, especially as I said, that you can easily note that there are lytic lesions, especially on the lateral view. And maybe, as I said, this should warrant further investigations into the cause beyond this fracture. Now, can someone please tell me, especially by looking on this image, is this fracture angulated or is it not angulated? Can someone tell me? Now let's start to apply some knowledge. Is it angulated or not angulated, this fracture here? So it's angulated, yes, perfect, it's angulated. Even if you start looking on the other image, it's showing you how angulated it is, okay? So if you, as I said, if you walk through the image with your mouse through the center of the bone, you will not be able to do this until, see, my cursor has to take an angle for it to proceed. So this is an angulation here. And as I said, this patient has a pathological fracture. Start thinking of something like multiple myeloma, or start suspecting this if the question mentions something within the realm of malignancies, okay? Now, this here is just the normal elbow joint. Now, they're giving us the normal anterior-posterior view and the lateral view. Now, key points that I think we should cover, and I want you all to know, is that usually elbow joints, they have these characteristic injuries, and each of them has like its own characteristic appearance. So if a patient has an issue with their elbow, sometimes you will only be able to notice that they have some soft tissue abnormality, and you will not be it's not going to be an easy job for you to spot an abnormality on their fracture. Now, this is not with all the cases, but sometimes it's very handy for you to notice the subtle soft tissue abnormalities whenever you're looking at elbows. And also, elbows are of particular interest, especially with pediatric population, with the younger population, because we talk about them a lot in the context of growth and the growth plates within the shoulders, with the growth plates within the elbows. So we always pay very good attention whenever a pediatric patient presents with any issues around their elbow joint, okay? So in this image, we would like to just go through the anatomy of a shoulder joint. Now, as I said, I would suspect that you would not get questions that are asking you about the anatomy. They'll probably be asking you to define the lesion. So I wouldn't really stress on this. This is not where I would put 100% of my effort. I would just go through these, but as I said, I would put 100% of my effort into, or 90% of my effort into learning the pathologies, not just learning the anatomy. This is useful for you to learn the pathologies, but just don't pay too much time on this, okay? So this is a normal elbow x-ray for a 10-year-old child. Now, everything is labeled by the first letter. So this is the capitulum. Now here, this is the radial head. The eye is pointing to the internal epicondyle. The T here, I don't see the trochlea. Okay, the T is pointing through the trochlea. And then if we start looking at this image, the C here is pointing at the capitulum. The R is looking at the radial head. The O is looking at the olecranon process. Now, if you're just confused what the L is pointing at, now the L is just telling us that this is the site of the lateral epicondyle, okay? Now, this is not present on this image because this ossifies with age. Now, ossifies means turns into a bone. This is just a fancy word of saying a bone is created, okay? So this ossifies with age. So because this is a 10-year-old child, we cannot spot the lateral epicondyle here. And this is a useful technique for you if you want to know an age of a patient just by looking. Sometimes we just look at the lateral epicondyle, and knowing the age of a patient by the look of their bone is a very common practice, especially for forensic medicine, okay? I just want you to notice before I proceed, this is very important. Now, I would say this is the most important note on the slide. Just want you to notice how the capitulum is in line with the anterior humerus, okay? You can just see this is the capitulum. This is the side of the humerus. And look here, the humerus, this is the anterior humeral line. This is the capitulum. So if you're going through the anterior humeral line and down to the capitulum, you shouldn't really get any displacement while you're going with your cursor, okay? So they should be in line. This is quite important now that I move to slides which show us how fractures look like, okay? So looking at this, now this, as I said, this patient here, now they have an issue with their elbow. I cannot spot a lateral epicondyle, so I'm going to assume that this patient is a young patient. And if you look at the distal humerus, now I would say here, this patient has a fracture at this side, at the distal humerus, okay? So maybe you're not really sure from this side, but it's always easy if you're looking at the lateral side. Now, if you look where my mouse is here, and you start looking especially at this collection, now all this area and collection that should be here, now this area of darkness, okay? This should be pointing towards that this patient has some sort of effusion. Now, this is what we term as hemarthrosis. It means that they have blood within their joint. Now, remember, arthrosis is just referring to the word joint. That's a fancy Latin word for joint. So this patient probably has hemarthrosis, and this is very common if you get a fracture in your humerus, okay? And because this is a very small joint in size, now this is going to cause some pressure on the muscles here. Now, normally, if you have hemarthrosis, the pressure is going to be thrown on the muscles. But however, because the triceps muscle, which is normally here, is very powerful, now this is not going to affect the muscles as much as it's going to affect the bone, okay? So if you start looking again at here, as I said, you need to just start looking at the capitulum, which is here. It should be in line with the anterior line of the humerus, but now we cannot do that. So if you're going here, you cannot go in line with the capitulum, like it says here. So here's the anterior humerus line, and here's the capitulum. So this is pointing us to the fact that this patient has a fracture within their humerus, okay? Now, this is just normal X-ray. Just let's say this is an opportunity for you to remember that if you're looking at the wrist bones, that you have the scaphoid, the lunate, the triquetrum, the pisiform, the trapezium, the trapezoid, the capitate, and the hamate, and they're all quite outlined for you. Now, as I said, I wouldn't really concern myself so much with normal anatomy. I just go through the slide maybe once or twice. That will probably be enough. And I will confirm with the department whether you will be asked about normal anatomy or not, okay? I'm not taking full responsibility for this. So please wait until I send you a message to confirm whether normal anatomy is part of the discussion or not. Now, if you look at this image, now this is still, we're looking at a normal X-rays and a normal X-ray, and it's giving us still the names of the bones of the hand. Now we moved up from the wrist. So these are the metacarpals. These are the proximal phalanges. This is these are the middle phalanges. These are the distal phalanges. So same applies for all the bones. So can someone tell me what is the name of the bone that I am pointing at? Is this a proximal, middle, or distal phalange here at the thumb? Proximal, middle, or distal? Here, this bone. Proximal, okay. So what is the name of this one? The one that's above it. Distal or middle? Distal. So there's no middle, okay? So this is just the point that I'm trying to make here. So within the thumb, we don't have middle phalanges, okay? So this is just the point that I'm trying to make out. Okay. So this patient here, the image that we're given, this patient here has rheumatoid arthritis. Now, how can we tell that this patient has rheumatoid arthritis? Itis means inflammation. Arthritis means inflammation of the joint. Whenever these patients have inflammations of the joint, you start noticing that the joint spaces are almost obliterated. So you can see here, this is a normal joint space. You can't spot it here, can't spot it here, you cannot spot it in here. So you start noticing that something is wrong. You start to see some misalignments between the joints. So what do you look at whenever you're looking at rheumatoid arthritis? You need to spot the marginal erosions. You'll start noticing that the margins of the bones are eroded. You'll start to notice that you cannot really visualize the joint spaces, so you get narrow joint spaces. Can someone tell me, why do we get narrow joint spaces? Now, this is an important question. Can someone tell me, why do we get narrow joint spaces? What happens because that causes narrow joint spaces? Okay, I'm going to give you a hint. We lose something. It's because of arthritis, but we lose something. What is the structure that we lose? Okay, so I'll make it easy, the cartilage. Perfect. So just for you to remember, now this area of darkness here, this is not air. This is dark because on the image, because it's not bone. This is cartilage. So there's an actual structure. There's supposed to be cartilage. Now, when you lose the cartilage, what happens is that both bones, the articulation between both bones becomes more direct. That's why you lose this. So that's why loss of cartilage would mean loss of space. Okay, so just keep that in mind. Now, as I said, we get loss of space here or loss of joint space here in joint arthritis. Can someone tell me another disease where we could get loss of joint space? Another disease? We discussed it in one of the images. So rheumatoid arthritis, and it's a disease that, as I said, most common osteoarthritis. Perfect. Thank you, someone. Osteoarthritis disease, as I said, most commonly we see it in the context of wear and tear in the older population. Okay. Okay. So now we'll start looking at the lower limb X-rays. Now, this is a hip joint X-ray, and this is a normal one. Now, this is how a normal hip joint looks from an anterior-posterior view. What I would like you to know here is just this is the femoral head. Just need to know that this is the femoral head. Need to know that this is the femoral neck. You need to know that this is the greater trochanter, and this is the lesser trochanter. And what runs between the greater and the lesser trochanter is the intratrochlear crest. Okay, so this is the line that runs between them here. Okay, and then I want you to know that this is the obturator foramen, this dark area here. I think that's about it for this image. Okay. Yeah, okay, so this one is actually labeled. So here he wants you to know that there's something that we call the Shenton's line. Now, I would not overwhelm myself by trying to memorize the anatomy of it, as much as I would like you to know what the Shenton line is. So you just need to know what you're looking at. So it says here that the Shenton line is formed by the medial edge of the femoral neck. So this is the femoral neck, and medial side means it's going more towards the spine. So I think the spine should be here. So this is more medially. So it says from the medial side of the femoral neck and the inferior edge of the superior pubic ramus. So this is what we call the Shenton's line. So why do we need to know the Shenton's line? Because this is what we assess whenever we want to see or want to make sure that a patient has a fracture in the neck of their femur. Now, an easy way, without going into all these complex complex procedures whenever you want to diagnose a femoral neck fracture, just gonna notice that the femoral neck is shortened. It's just easy to spot, even whenever they're trying to, like, it's very obvious that this is a very short neck. It's not, especially if you have the other side visible, but it's very obvious that this is a very short neck. Now they want you to go through, as I said, the medial side of the neck and the inferior edge of the superior pubic ramus, and go like this. So it says here, if you're going with the inferior side of the pubic ramus, there is an interruption because this is where the neck of the bone is. So it's not that they are continuous. So here's the neck of the bone, and here is the inferior edge of the superior pubic ramus. But as I said, the shortened head, that is just way too good for you to go. And also because if there's a shortened head, there's probably going to be bone overlap. Now, you probably know by now that on an X-ray, bones are white. So if you see too much white, means that there's too much bone. And this is where you get bone overlap, okay? So if you get bone overlap, it means one side of the bone is above the other side of the bone, which would be very common in an anterior posterior view. There's an overlap, then you're going to see an increase in the density or increase in the whiteness that appears on the X-ray, okay? Now, if you look at the lesser trochanter at this image, I want you to look at the lesser trochanter at this image, okay? Please keep a good eye on this. I'm going to give you like 5 seconds to keep a good eye on this. So this is the lesser trochanter here, okay? On this patient who has a fracture. Now, I'm going to move back to a normal image. Now, look at the lesser trochanter here. So what's the difference? Can someone tell me? Can someone tell me what's the difference between this lesser trochanter and this lesser trochanter? What's the main difference? Lighter? Well, give it another guess. Again, look at this lesser trochanter. And then look at this one. What's the main difference? Again. Okay. The size. Perfect. Thank you, Wadaina. Perfect. Perfect. So this lesser trochanter is bigger. Perfect. Thank you. Thank you, Wadaina. Thank you, Samar. Thank you, Reem. Thank you, Ale. This is, all of you give the correct answers. So this lesser trochanter is bigger in size. Now, this increased prominence of the lesser trochanter, this should be a sign for you to know that the bone is just not fractured. It's also externally rotated, okay? So there's some rotation that happened to the bone after the fracture. Now, I would write that note down. I think that would be a good use if you ever get this image on your exam. It's definitely gonna impress the examiner, definitely gonna earn you extra points, just to say that this prominence guided you to noting that this femur is more externally rotated, and the shortened neck guided you to noting that there is a fracture to the neck of the femur, okay? Now, as I said, this is this is what we call the intracapsular fracture on an anterior posterior view. Now it's in yeah, okay. So let's not go into much more detail. So this is a subtrochanteric fracture. Now, the fracture, as I said, this fracture should pass distal to the trochanters. Now we know that this is the greater trochanter, this is the lesser trochanter. Now, if the fracture passes distal to the trochanters or below the intertrochanteric line, so if you're looking here, then this is what we call a subtrochanteric fracture. Now, why is this of importance? Because when you say, or when you use the term subtrochanteric fracture, it means by default that you're saying that the femoral neck is okay. So this word just serves to say that you're confirming that there is a fracture, but it's not in the neck. It's not here in the neck of the femur. It's just beyond the neck of the femur, because most probably on, as I said, most probably on a physical examination, both will seem very similar. However, why am I stressing on that we need to confirm that this is not a fracture to the neck? Because a fracture to the neck of a fracture to the surgical neck here, this will most probably cause necrosis. So it's very easy for a patient to get necrosis if they have a femoral neck fracture. So this is why we have this term, the subtrochanteric fracture, is just to ease the worry that, okay, this is beyond or this is below the neck line, even though they would look similar on physical examination, okay? Now, what we have here is a hip dislocation. So as I said, we just need to know where the acetabulum is. So here's the acetabulum. Now, this is just not normal, okay? So the femoral head is superior and lateral to the acetabulum. Okay, this is what the acetabulum is, and this is a much better definition than my mouse. So this is dislocated. So patient has a dislocation. This is very common in old age, especially after falls. So as I said, the femoral head is more superior and lateral to the acetabulum. But if you look at the image here, and if you follow the cortical outlines of the bones, you'll notice that the patient doesn't have any fractures. So it's just a dislocation. Now, even though I'm looking at this image and I cannot see any of what I'm going to say, but if a patient has hip dislocation, it's very safe to assume that they have soft tissue, even though it's not evident on this image, but it's very safe to assume that a patient who has hip dislocation would have some soft tissue image, okay? So moving on. So this patient here has a femoral shaft fracture. So this is a spiral fracture. And now you can start to notice what I mean by a spiral fracture, okay? Because we can see it on both sides. So it's not just a one line and one trajectory. It has this 3D curvature nature to it. Now, it's not a comminuted fracture because there are two fragments of the bone. So this is what we call a spiral fracture. Now, this patient here, they have some sort of angulation. Why? Because look at how the mouse is going. So if I'm going here in the middle of this fragment of the bone, if I want to continue, I'll have to take an angle. So this patient has an angulation, okay? They have a lateral displacement and they have shortening. Now you can spot the lateral displacement here because there's this area of emptiness. So it means that if I approximate both of the bones, they're not gonna meet at 100%. There is some displacement here, okay? And it says also that this patient has some shortening because why do they have shortening? Because there's some overriding of both of the segments, okay? Here's where the overriding is at this area, okay? So let's move on. So this is a normal knee joint. Again, I wouldn't overstress myself with learning everything about what is normal. But I would like to confirm that piece of info. But again, we're looking here at a knee joint. So this is the patella or the kneecap. This is the femur. We have here the lateral femoral condyle, the medial femoral condyle. These both are the tibial spines, lateral tibial plateau, medial tibial plateau. This is the tibia and this is the fibula. Okay. Now let's speak a little bit about tibial and fibular fractures. Now, this is the patient's left leg, okay? Now, this patient here, they have comminuted fractures of the tibial and fibular shaft. Now, why do we call this comminuted? Now, look here from the anterior posterior view. So, you have 1 segment, 2 segment, 3 segment, 4 segment, 5 segments, 6 segments. So, yeah, that is what we call a comminuted fracture. Now, look here from the lateral view on the other bone. So, 1 fragment, 2 fragment, 3 fragments, okay? So, these are comminuted fractures. Now, does this patient have any angulation? Let's go with the mouse. And if I want to proceed in the middle, I have to take an angle. So this, as I said, especially from here, if I want to proceed, I have to take an angle, okay? So there's angulation and there is medial displacement. Now, as I said, you need to be well oriented, where is medial and where is lateral. Now, if you look at the muscle structure, now you'll start noticing that this reminds you of the normal anatomy of your legs that you know. So you can say this is probably the medial side without even doing any extra effort, okay? So let's move on. Now, let's talk a little bit about the ankle joint anatomy. So this is the fibula, the tibia, everything is well labeled. I don't think there's any confusion if you look at this. So this is the lateral malleolus, the medial malleolus, and the talar dome, the tibial palafond, the ankle joint space, which is the one in red. So everything is quite labeled. There's good labeling on this. Now, you're not really, I don't really know if you're going to be asked to say whether this is a Weber A, Weber B, or Weber C fracture. However, I'm going to explain this just for the sake of the possibility if this ever rises in your exam, okay? So Before we start discussing the fracture, just notice this area here, which is quite swollen at the blue area, okay? So this is showing us that the patient has some soft tissue swelling on the lateral side, okay? So this is what we should be noting here. This should point us that before we look at the image, that there's probably something wrong. Why am I saying that? Because this fracture is labeled, or it's not labeled, it's overlaid here with red, with a dark color. So this is easy to spot because they're giving you, they actually painted this in black, okay? But if you're looking at this image without them pointing it out, sometimes you're gonna miss this. So what points you towards noting that this patient might have a fracture and you need to look more carefully is the soft tissue swelling. So the soft tissue, this is not normal. You shouldn't have this bulge here, okay? So after that, you should start looking for a fracture. Now, if the fracture is at the fibular tip here, this is what we call as Weber A, okay? This is what we call by Weber A. Now, if the fracture is above the ankle joint, that is Weber C. If it's in between, that's Weber B, okay? I really doubt that you will ever be asked about the Weber classification. Just know that sometimes a soft tissue swelling is going to be your only aid to spot a fracture on one side. The best aid for you is going to get another side of the image or another view of the image. A lateral view for this fracture is going to be perfect. It's going to show you everything you need to see. Now, this is a dorsal plantar view. This one here, this is an oblique view of the foot. I would rather know my views quite well. So this is very useful because you're going to say what view you are looking at on every image you comment on. So start developing a habit of knowing the name of the views. So this is a Z, this is a dorsal plantar view or a DP. And this is an oblique view of the foot. Okay, now this patient here has a metatarsal fracture. Now it's much more obvious here on the oblique image than it is on the dorsal plantar one, okay? And this is on the 5th metatarsal joint. Now, before I proceed, does anyone have any questions before we start talking about axial skeleton x-rays? Any questions so far? Everyone okay? So all good, okay, all good. Now, can the rest also please confirm? Sometimes I'm worried that some of you are suffering in silence, which is something, I don't know, it haunts me all the time. So just please confirm everyone that everyone is okay up till now, because this is the majority of the lecture that we went through. So I don't want anyone falling behind. So we don't leave anyone behind, okay? So everyone else is okay? All good? Okay. I'll take that as a okay. So someone, yes, okay. So this is why I do this. So someone told me they want to look at the oblique image on the previous side, on the previous slide. Okay. So this is the as I said, this is the dorsal plantar view. Now I know the fracture is obvious. You can start if you're walking with the cortical outline, you're gonna notice the fracture. It is there. However, here the displacement is way more obvious. Now this is an oblique fracture because this is a clean line. It's not very spiral. There's not very there's not much overriding of the bones. So especially from this view, this view is very useful for us to know that this is an oblique one, not a spiral one, because from this view there's no overriding. It's not a 3D fracture. It's just a line. Maybe there's a slight angle to it, but still it's oblique. Okay. For the person who asked me the question, are you comfortable with this explanation? Everything okay? I'm just going to wait for you. Go ahead, proceed. Okay, so it's just a lot of silence. So I'm just going to assume that you're okay until you maybe ask me. Oh, so it says now how I will differentiate. So, the question is, how do you know, is this an oblique or dorsal? Okay. So I probably misunderstood the question. So you're probably asking me how I tell this is a dorsal or a dorsal plantar or an oblique. No, you don't. You don't. because you will never be presented with only this portion of an X-ray. There is no imaging modality where this is the final product. You're going to be faced with this. Okay, so this is very easy to spot on that this leg is oblique and this one is, these are two very different views. Like you can easily tell that this patient's leg is not the same position as this one. Let's proceed. So now we're going to have a small discussion about the X-rays of the axial skeleton. So the axial skeleton means, by the axial skeleton is just everything that runs within the center. So it's the skull, your spine, the sternum, the ribs, because they originate from the center. Let's say basically anything that's not your limbs. So if it's not your limbs, we're probably referring to the axial skeleton, okay? So this is a skull, and this is the normal view of the skull. Now, normally, when you look at a skull, it has what we call the inner and outer surface. Radiologist likes to call them tables. So this is the outer table, the one that I'm going through with my line, with my mouse cursor, this line on the outside, and the one on the inside, that is the inner surface or the inner table, okay? So just note this is not abnormal. This whiteness here, this is just very normal. Sometimes people get that confused, okay? Now, this is an anterior-posterior view of the skull, and I would like you all to zoom in on your screens. I know some of you are using their phones. So if you zoom in, you'll start to see these suture lines. And these suture lines, they have this appearance which we call a sawtooth appearance, okay? And a sawtooth means that, just look at my mouse, it looks like this, like a zigzag line, okay? This is what we mean by a sawtooth appearance. So these suture lines, they have this sawtooth appearance. Now, if you want to memorize these, just okay, it's good for any doctor to know the names of the suture lines. We have the sagittal, the coronal, and the lomboid. Now, why are we stressing on this? Because some people would look at the suture lines and think, oh, this patient has a fracture. No, a fracture would not have this sawtooth appearance all along the line, okay? So this is not a fracture. If it's smooth, if it has this sawtooth-like appearance or the zigzag line appearance, then you're looking at a suture. Now, if you're well-versed in anatomy and you know where the sutures are, this is never going to be a problem for you. So, a skull fracture, how do they look like? So this is very evident here, and you have these fracture lines on both sides. So the black lines here, they represent skull fractures. They are too smooth to be sutures, and by that we mean they don't have the zigzag appearance that I just discussed. And someone would think, okay, why wouldn't I say that these are just vascular markings? Now, vascular markings, maybe you're thinking a vessel is running here, and because a vessel is running here, maybe you're not very confident about your anatomy. So maybe because a vessel is running here, you'll be thinking, oh, so it has like fast flowing fluid on an X-ray. This should appear dark. So maybe this is just a vessel. However, this is not a normal branching of a vessel. So you never see a vessel that is branched like that. So don't get that confused, okay? Now let's look at the cervical spine or the C-spine. Now the next slide is labeled, so it's going to be much more useful. Now, whenever you are looking at the cervical spine, there is also a systematic approach. So first of all, you need to, or the first step is coverage, which means that you need to make sure that you can spot all your vertebrae from C1 to C7 because you're assessing the cervical spine. So you need to be able to count 7 of these, which means that, okay, everything is visible. Now, the C1 will not be necessarily visible, but if you're spotting everything from the top of C2, that means that you are getting good coverage. This is a good image of the cervical spine. Then you need to make sure that everything is aligned. Now, when you're doing this alignment practice, you just go through the anterior line, this one here in green, just make sure that everything is normal. Now, this is a normal curvature of the spine. Everyone has this. And then you look at the posterior line, which is supposed to be where the posterior longitudinal ligament is, and just make sure that also it runs quite smoothly with the same angle. And the one here in orange, the line that's running here in orange, I said this is the posterior line, excuse me. excuse me for looking at excuse me for going to the gut, excuse me. Oh, so this is the anterior line, excuse me for my mistake. So the green one here is the anterior line. The orange one here is the posterior line. So this is what you go through if you're looking for the alignment. The red one here is the spinolaminar line. So you go through all these lines and make sure that they have the proper curvature. Excuse my the hiccup I just had. So this is how you make sure that everything is aligned. It's actually much easier than all this systematic approach. I'm going to show you images, and it's way much easier than having to go through all this, okay? And then with the bones, you just trace the cortical outlines of all the bones just to make sure that there are no fractures. After that, you need to look at the disc spaces. I know a lot of you have some family members who have issues with their disc spaces. Maybe they have any problems with their back or their cervical spine. So you need to make sure that the vertebral bodies are spaced apart with the intervertebral discs. Now these are not visible with the x-rays. They should look more darker, okay? And you should look at the prevertebral soft tissue. So sometimes you would get widening of the prevertebral soft tissues, especially if you have some sort of hematoma. So this is what we're pointing at here with the asterixes, these little stars. So this is pointing at the hematoma, okay, in a patient here. Now, whenever you're looking at a sternum, at this case, just need to know that this is how a normal sternum and manubrial joint looks like, because there's this line here, oh, excuse me, here, sorry, so here, this is sternum-manubrial joint, because this line here, sometimes people mistake it for a fracture, okay? So this is one of the things that you need to know how it normally looks like, the sternum-manubrial joint. Excuse my cursor from earlier, okay? So where the sternum-manubrial joint is, and you need to make sure that you know how it looks like, because you should not mistake it for a fracture. Now, sometimes you'll be given an image of people who have rib fractures. Now, these are particularly easy to follow because this one here, this patient here has multiple rib fractures. You'll see that the ribs are not continuous. They just stop at one point, and then the fragments are also non-continuous. They just stop at one point. So this one here is, by the aid of Photoshop, I think, is much better visualized. So you can see here, there's nothing continuous. So this patient has multiple rib fractures, okay? So this is a thoracic spine from a lateral view and an anterior posterior view. So you just make sure, as I said, you start looking at the alignment. Now, what I like to do is I just look at the spine, usually. This is what I like to do. Just if all the spines are aligned, so this is the spine here. So if all these spines are aligned, this is enough for me to make sure that this is well aligned. I usually don't go with the right border and the left border. However, this is easy. You just go with the right border, it's aligned. Go with the left border, it's aligned. You go with the processes in the middle, they're aligned. And this patient has, they have proper alignment, okay? So whenever you're looking at the thoracic spine, you also need to make sure that there's good coverage, that you can count all the thoracic spines down to T12. And then you go through as I said, through the right border, the left border, and through the spines in the middle. And then you start looking at the spacing between the discs. So you make sure that everything is normal. So there's a space here, 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 and going down. So these are 12 discs. I'm not gonna like point at each and every one of them. And then I just want you to note that because there's a like this is magnified. So, and because of there's what we call the spinal curvature. So the vertebral bodies and the discs at the edges of the image can sometimes appear larger than those at the center of the image. So sometimes you might look at an image like this and you start seeing that this seems way smaller than this. But this is just because of the normal curvature of the spine and because this is magnified. So this isn't something that should worry you, okay, on an image. Now, if I'm looking at a lateral view, so here's my spine. So I start going with the anterior line, the posterior line. This is just enough for me to make sure that this is aligned. If you want to take a look at the disc spaces as well, this is also going to be useful for you, okay? Now, you're never going to get an image this big, which has something wrong with the joint spaces unless it's very evident. But you can get an image this big if the patient has some sort of dislocation or fracture, okay? So Now this patient here, they have a fracture in their spinal processes, which is here. You can see it here, here. So this area of darkness that goes through the spinal processes. Now, if you go through the cortical outline, you can go like this, but then there's a discontinuity. You can see this discontinuity here. Now, this is an oblique one, as I can see from this side. But as I said before, one view is no view, but I would assume that this is an oblique fracture. Now, it's definitely not a comminuted fracture. It's definitely not a transverse fracture. And sometimes you might get confused whether it's this spiral or is it oblique. Well, if you're given one view and you can safely assume that there's no overriding of bones, you can just safely assume that this is an oblique one, okay? Now let's go through the pelvis anatomy. Now this is the normal anterior posterior view. Now I'll just leave you guys to look at this at your own leisure, because I think we already discussed this from we discussed this from a more zoomed in view before. So before we finish, I'm just gonna discuss a little bit about DEXA with you guys. But if you excuse me, I'm just going to have to mute myself for 1 minute and I'll be back. Okay, just 1 minute. Okay, so I really don't know how to mute the slides, but just I'm going to use this slide to point out that a DEXA scan is a dual energy X-ray absorptiometry. So just know the full word. Know the full word. On one oral exam, that was the only question I had. What does DEXA stand for? So just know the full word. So this is an imaging technique or an imaging modality that we use by using X-ray. So by using X-ray mean that it has all the issues of radiation. So if someone asks you, what's the downfall of using a DEXA, just mention everything that's wrong with using radiation, okay? And we use that to measure the bone mineral density. So where do we assess this? We usually use the lumbar spine and the hip. How many, do all the slides have sound? I hope they don't. So as I said, the lumbar spine here, whenever we assess the, I don't know why they keep moving, excuse me for that. And I don't know how to shut the voice down, so sorry. As I said, the lumbar spine here is just used to, it's one of the points of assessment whenever we want to assess the density of the bone. Okay, this, I know probably you guys are as annoyed as I am. So when on a lumbar spine, what we do is we ask the patient to lie supine, because when they lie supine, normally everyone has their normal lordosis. Now, lordosis means the inward curvature of the spine. So if you're standing and you're looking this way, so a lordosis should look like this, okay? And the other point that we use to assess the bone density is also the hips. Now we ask the patient to keep their knees and hips flexed, which is like pulling your knees to your chest. So if some of you just pull your knees to your chest, then you have both your hips and knees flexed. So that's the position a patient is in, supine, and they get their knees and hips flexed. Now we just use the forearm also to assess the bone density, and we use the whole body. Now again, excuse the sound that keeps going, but I think it just stops talking from now. So how do we interpret, oh, it doesn't. Okay, I don't know what to do with this. Okay, so how do we use that? We use something that we call, I don't know. Just give me 1 second. I just need to figure out how to stop this from talking. Okay. Okay, here it is. So this is, again, so now we're going to discuss the, how do we interpret the DEXA scan? Now we use what we call the T-scores. Now a T-score is just a fancy statistical term. It means how far are you from the mean. What do we mean by the mean? Now we just normally get a population of people, let's say 1,000 people, and we assess the density of their bones. Now let's say that we say that their density is 10, for example. Now, how far are you from that number, 10, which is the mean score or the average score for a bone density? That is what we term as a T-score. Now, if you are at -1 or less than -1, so anywhere between 0 and -1, that is normal. So that's a normal deviation from the mean. Now, if you are beyond -1, so you're anywhere between -1, -1.5, -2, up to -2.5, that is what we call as osteopenia. Now, the term osteopenia just refers to what we term as weak bones. So these are weakened bones. They don't have as strong minerals supporting them as they should. Now, if you have a T-score that is lower than 2.5, so we're speaking something like -2.5, -3, -3.5, so on, that is what we call as osteoporosis. So if a patient has osteoporosis, the next thing we do is that we look at the Z-score. We look at the Z-score. So what is a Z-score? A Z-score is also another fancy statistical term, but it just helps us to know whether this is primary or secondary osteoporosis, okay? So if you have a Z-score that is lower than -2, then you have secondary osteoporosis. If it's greater than -2, so if it's -1, -1.8, -1.9, then you're thinking that this patient has primary osteoporosis. Now, I know some of you, probably most of you, started looking at these images and they felt very worrisome that something is missing. How are they supposed to interpret this and know what the density is? Is this just a game of colors or so on? But no. Whenever you are presented with this on your exam, you're going to be presented with the image and the tables. So the only thing that you need to do on if you're faced with a DEXA scan is that you need just to look at the T-scores. That's all you need to do. So if we're going here, proceeding with here, you can see that the L1 has a -2.1. So that is less than -2.5, but is more than -1. So if you look at this, so this patient has osteopenia at the L1 region, osteopenia at the L2, because this is less than -1, but more than -2.5. L3 seems normal, L4 seems normal, everything else seems normal. So I'm just going to say this patient has osteopenia at the L1 and L2 level, okay? And then this is another scan. So I really wouldn't concern myself with these images because they're not giving us any information. So where are we getting our info from? By looking at the T-score. So all the T-scores here are greater than -1. So this is a normal DEXA scan. Now, this is a patient who has primary osteoporosis. So I'm not looking here. I'm not looking here. I'm just looking at the T-scores. How do I know that they have primary osteoporosis? -2.9. At the neck, the T-score is -2.9. So that's not normal, okay? So the -2.9 here is less than -2.5. So I immediately say, oh, this patient has osteoporosis. At the wards, -3.8. At the TROSH, -3. Total is -2.9. So this patient has obvious osteoporosis, okay? Now, this is another image here where they're showing you secondary osteoporosis. So again, I will go here and I'm just reading the T-scores. So all of these T-scores are obviously very low, -4.1, -4.2, -4.3. So what's the next step? I start looking at the Z-score. Now, since the Z-score here is lower than -0.2, so this is -2, excuse me, so this means that this patient has secondary osteoporosis. Now, here's for a patient who has osteopenia. Now, it's saying here this patient has white, this is a white female, they usually are. So then you look at the T-scores. So it says here that the neck, the T-score is -2. So this is osteopenia. If it was -2.5 or less than -2.5, this patient would have had osteoporosis. And finally, you get this. This is a whole body DEXA report. So you do the same thing. You just keep looking at the DEXA scores.